Dr. Lalit Kumar Sohan Raj, who practices at Ashwini Eye Clinic in Saukarpet, Chennai, and a very dynamic, very innovative surgeon. So we look forward to his case. Yes, yes.
A very good evening to one and all, and I'd like to thank AIOS, ARC, and Chitra Madam for giving me this opportunity. There were wonderful videos. I don't know whether my video will actually, be good enough for this thing, but I'll try my best. So this was a patient who came with a persistent pupillary membrane, as you can see here, and actually it really looks scary in the beginning to handle cases like this, but actually it is very, very simple. And I handle these cases by using iris hooks. The only key here is we have to know where to put the iris hook. So you have to go to the extreme center, get one of those membranes, try to pull it. See, now it has not come very well. The first iris hooks is not helping me very well. It is not stretched the iris the way I wanted it to. So I'm with the second iris hooks, I'm just going in and trying to hook the innermost part of the membrane and trying to stretch the iris. The first iris hooks also I did the same thing, and you saw all the membranes just gave way. And it is just like a routine case of cataract surgery after that. So I went ahead and I fixed 4 iris hooks. As you can see here, I'm just putting the 4th iris hook. And here, as Hiron Madam said, that the place where you put the iris hooks is also important. So I place my incisions at the limbus. So not very scleral, not very corneal. It is at the limbus, and there is absolutely no tenting of the iris if I do it that way. So once that is over, it is just a routine cataract surgery. You can see that I've completed my rexes, but when I was putting my phaco probe inside, there were a few strands of iris, the membrane which were coming on in the way. So I put a 5th iris hook just close to my incision, as you can see here. And I did the hydrodissection. And my favorite technique is the stop and chop technique, which works very well in every situation. So I trench my nucleus, divide it into 2 pieces, as you can see here. And once that is done, this was a very soft cataract, though we were not able to gauge the density of the cataract because of the persistent pupillary membrane. Once the membrane was stretched and out of our way, we came to know that this was just a very soft cataract with a dense posterior subcapsular component. And it was very easy to emulsify this cataract, as you can see here. Once I remove my first piece, I always coat the endothelium with the chondroitin sulfate. So I use Viscoat in almost all my cases. Here I'm doing my cortical aspiration. So it is just like a routine case. What looked scary in the beginning became a routine case once I put the iris hooks. So once the cortex is out, I'm just implanting the intraocular lens, as you can see in this video. And once the lens is inside, this is a toric lens. You can see the toric marks also being done. So once I remove the hooks, I'm just going to do the cortical aspiration, as you can see here. But what I found was these membranes were actually coming in the way when I was doing the cortical aspiration, and I just wanted them to be removed. So I just stopped at that point of time. I injected a little bit of viscoelastic agent, and I just went with my long vanas. You can actually use microrhexis forceps. Unfortunately, that day I used it for one more patient, and I had only one microrhexis forceps available in the UK that day. So I just used my vanas. So I just used the iris spatula, as you can see here, the phaco rod, and made sure that these membranes are seen very clearly. And I went to the base, close to the iris, and just cut these membranes. So there are 2 advantages. One is they don't come in the way when we are doing viscoaspiration or whatever. And the second thing is it will not form a synechiae again. So you'll have a nice, I wouldn't say a very round pupil, but a very reasonably round pupil at the end of the procedure, and the patient will have better clarity of vision at the end of the procedure. So that brings me to the end of my talk, and I hope this video was useful for all the viewers.
Yes, Dr. Lalit, that was a wonderful video and not a very commonly. Can you stop sharing?
Anything different I could have done, because this was the only patient I have operated with a persistent pupillary membrane. This came to my mind, but all the dignitaries here can give me some advice if I come across one more patient like this. Anything different I could have done.
Very interesting case. I think placing iris hooks and keeping it all away and then cutting it at the right time. Maybe you could have finished your IA, but I think it was all very well managed very well done. It is just out of sheer curiosity. Even I haven't come across a situation like this. Supposing these pupillary membrane were dense, then would we have used a vitrector instead? It's just a theoretical question I'm posing.
Yes,
I
maybe
mean,
not a 23 gauge, maybe a 21 gauge vitrector, because
yeah.
there, 23 gauge vitrectors, I feel sometimes, even the previous case, right, even if it is a fibrosed capsule, I personally feel a 23 gauge vitrector might not be that effective. Maybe a 21 gauge would be a better option in these situations.
Yes.
What if you had cut those membranes at the pupillary margin in the first place only?
Why would you do that and damage
No,
the
no,
lens
no, no,
capsule?
no.
Anterior capsular
Only the
tear or something.
membranes. What he did at the end,
Yeah.
if you just snip it, because they were just gentle fibers across the pupil. So just at the pupillary edge, if you had just cut it off, they are not vascular.
But they
So
will still come in the way, madam. When I'm doing phaco, they'll still come in the way. So first thing is to keep them away so that I have access to the cataract first. And then, if at the end, if it bothers me, I thought I would cut. So it was bothering me, so I cut it at the end.
Yes. Yes. Wonderful case you
sir
showed, Dr.
wanted to say
Lalit.
something. Sir is saying something.
We are
Can
already
I?
running late. Yes.
Okay, all fine.
No, you want tiny comment. I don't
No,
want the teacher to get full swing. I want one
yeah,
comment.
because one thing is these pupillary membrane are not attached to the pupillary margin. They are attached at the collarette.
Correct.
So we have already published two case reports. One, there was a full membrane which we removed surgically. Another, you don't have to do anything until unless they affect the vision. So here it was a case of cataract. The other ways we have reported also, we can do a pre-surgery yak capsulotomy near their attachment to the collarette because you don't want to injure the lens. So you can do a filiform these attachment of membranes with the yak capsulotomy. Way back in 95, we published in Journal of Imaging and this thing, and the another case is in Archives of Ophthalmology.
Okay. Thank you.
Thank you, sir.
Yes. We shall now go on to a last speaker. I'm sorry you became the last speaker. Dr. Ajay, that phone call disturbed me. Who's a director of Kesubai Mehta Eye Hospital, Rajkot, a very dynamic, very versatile surgeon from his area, and he's going to show us a different case. On to you, Dr. Ajay.
Yes, madam. First of all, thank you very much for the kind introduction. And Madam Chairman, I wish you and the entire AOS a very happy New Year, as in this part of India, we are celebrating Diwali and the New Year. So this case was a routine important patient posted for cataract surgery. So I marked the cornea for capsulorhexis, and because this patient wanted the best lens, we choose a preloaded lens. And so we made a capsulorhexis, and a phacoemulsification application was carried out as we do routinely in this medium hard cataracts. And so far everything was uneventful, and I was happy that the patient has paid a lot and I am going to give him back a lot. And now I started injecting a preloaded IOL. And then a lot of froth came out from the IOL injection. And then what I noticed at the end, and to my surprise, the trailing loop was not there. And this shocked me a lot, but then I was ready for this event. So I introduced micrograspers on one side, and then I bought a spatial, I had already acquired a spatial IOL cutting tweezers, which is very sharp, and I could split the lens into two parts. And now I removed the IOL without enlarging the same, without enlarging the wound at all. And now I was wondering what to do. So we had a replacement lens available. And so I asked my staff to open a new preloaded lens. And then I did injection of the lens. And surprise, here the leading loop was missing. And so what I did again was cut the lens in two, as now I was an experienced surgeon in cutting lenses. And with this, I could now easily remove it to the same size incision. And of course, all the while I was protecting the endothelium. The second loop, the second piece, I could support and take it out with the help of a good dispersive viscoelastic. So now I thought that instead of a preloaded injection of IOL, let me load a lens myself under a good supervision and a good microscope, and taking all the necessary steps into consideration and putting the loops over one another. And then with all the confidence and intact, IOL was delivered a bag. And ultimately, the patient could achieve very good vision even the next post-operative day. And this is how the surgery ended. And hence, it's necessary to keep in mind all this for a good cataract surgeon. Thank you for your kind attention.
Thank you very much, Dr. Ajay. I think it was a particular brand of lens. Was it a hydrophilic IOL which we're using?
No, madam. So actually, this lens was from Zeiss, a preloaded lens. This was known as 611PY.
City Lucia.
So, yes, City Lucia. So ultimately, I sent them the videos into Germany also, and I lodged a complaint with them. So at that time, they denied that this has happened for the first time, but slowly in another 2 months, a lot of other surgeons complained. And now it's nice to hear that they've withdrawn the lens from India and now introduced a new system, which is known as 621PY. That entire system have taken back.
Yeah, it's just a one-odd situation, but I suppose these becomes more challenging when you're doing a premium IOL of a different high IOL power, and you don't have a battery of lenses with you. And those are the moments when it becomes difficult as to how you can deal with the moment. But of course, this was a preloaded lens, but invariably if a trailing haptic gets cut in a normal situation, it is something about not adequately loading it properly, the trailing haptic, which is when it would get cut. But this was a different scenario altogether. Any opinion before from the Dr. Arun or Dr. Anagha before we?
Sometimes if the viscoelastic put is also less, but anyways, it
Yes.
was a, yeah,
Yes, true.
very unfortunate
So,
and one-off situation.
Actually, the preloaded system was made so that these complications don't happen.
Yeah, but
Yeah.
the
But
viscoelastic,
unfortunately,
yeah, unfortunately.
I know, unfortunately.
it has happened, yeah. And so that's why I think the best thing to do is put the lens in the direct vision, and that will probably solve all the problems.
Yeah.
Yeah, but this is the only lens which is sort of heparin surface modified. So it has special indication. I use it a lot, especially in all uveitis cases or where there's a lot of inflammation, post-inflammation. There's no other lens in the world which is heparin surface modified.
Yeah.
So still I use them, but it never happened to me, touch wood.
No, but now they have the new system, right?
Yes.
No, even before I'm using for last 10 years.
Okay.
Right.
Yeah.
Thank you very much. Dr. Sanjay, you have any comments to add before we conclude for the day? Oh, he's not
He
there.
is not there, yeah.
Okay.
Thank you, everyone.
So I think I would like to conclude this webinar, and it has been a truly interesting webinar with a variety of cases. And I think I really owe a lot of thanks to our very great set of speakers in this particular webinar. And I think all of us agree in unison that our expert panel also took on all the different questions which were thrown to him, so that different concepts about each of these topics are brought out very well for our attendees. And And of course, always thanks to Anagha for the brilliant support and involvement which she shows through all these webinars. I think I should also take this moment to thank Mr. Kripal and the AIRS admin for the varied ways which they support us. And a very, very special thanks is due to also all my ARC team members who are always there behind me and are very, very supportive. And I think that has to be remembered all the time. And thanks are due to Sai and Manjula from Numerotech for all those emails which keeps reading your inboxes. Thanks are very, very much due to Mr. Sunil. As you all know, as an webinar admin, how he helps in immediately within seconds coming out with the different videos and keeps you all informed, giving the link at the right time. Thank you so much, Mr. Sunil. And before I conclude, we should have seen this Entode video right at the beginning. Every single webinar of us have been sponsored by Entode, and we owed a lot to them. And let's see this video. And thank you, dear delegates, for coming and joining us in big numbers and taking us forward in our very, very overzealous